Hello, welcome everyone. Today we're going to have a little bit of a different session because it's cardiac. Woo! I love that. I love that. It's us. No, there's more people out there that do cardiac. But it's an honor for me to introduce you Christopher Nguyen, who is associate professor. Assistant? Associate.
I wish someday.
Almost. He's part of the Martinos Center, but also part of the Cardiovascular Research Center that's located at the fourth floor here. You're going to show some imaging, I guess.
Yeah, so it's great. Thanks, Mike. I really appreciate it. I wanted to thank the organizers for inviting me. It's been a pleasure, and I've seen that now it's grown. Before, when I was going on with the cookies and stuff, there was not many, and now it's everything. So this is great. I guess beer brings everyone together, right? It's like a beer summit. Okay. So in the limited time I have, I hope to go over three things that are sort of three stories that are sort of connected, and more importantly, sort of give you an update on those that are outside of the brain world, and to get you into sort of the cardiac world, and knowing that we're at sort of a brink in our sort of field of doing cardiac DTI. It's been historically done here, even though probably not everyone is familiar with that, but it's a very long history here of doing cardiac DTI ex vivo and then going into in vivo, and doing some of the first DWI images in the 90s. So I'll touch base on that. And then we'll talk a little bit of some validation that we do in our lab as well, and then some more of the recent technological advances. So, why do DTI in the heart? I think it's good to remember that we understand the sort of structure-function relationships that we have. If we zoom in and looking at the actual tissue, at the tissue level, not the cellular level, we realize that it's a syncytium that the heart has. It's conducting tissue, but at the same time, it has sort of this fiber-like architecture. And so if we can characterize that, we can start to get understanding early on, sort of the cracks in the building as they get sort of worse and worse, and maybe have some early predictors of sort of heart failure or heart disease in general. Another sort of finding that people have done and looked at sort of tearing apart the heart. Here is a boiled heart, where the top of the heart here, near that blue arrow, and as we go downwards, we're peeling off layers of the heart. And as you see in the fibers, visually with your own eyes, you can see that it goes sort of from a left-handed helix, a left-handed sort of twist. And as you go towards the middle of the heart, you have sort of a circumferential, meaning it goes sort of in a circle. And then oddly and interesting enough, on the right hand, on the bottom, sort of near the apex region over there, it's sort of right-handed. And so it's sort of this Russian doll concentric circle, sort of double helix structure. And it really makes sense when you think about it. When someone says, here's a towel full of water, why don't you get the water out? You don't just mash it like that. It makes no sense. You start to twist it, right? You start going, you take your left hand, you're twisting it this way, and you're doing the other with your right hand. So this is what the heart's doing, but sort of within itself. And so it goes right-handed and left-handed, and so that helps it sort of twist out the blood. So this unique structure actually doesn't have many crossing fibers, and so this is pretty ideal for DTI, and be able to sort of characterize this microstructure and see sort of it work in disease. And we've done this before. People apply a gradient, and they look at sort of this water molecule trajectory, and then they calculate a tensor, and you have these beautiful tractograms. This is actually an in vivo data set, but if you look at ex vivo, it looks very similar, if not better. And you can have these wonderful these pictures. But here's the problem, and I think a lot of you would kind of asking, it's oxymoronic, in vivo cardiac DTI. And with diffusion, everyone knows it's very sensitive to motion. And even here, if you do multi-shot DTI or multi-shot DWI, if you see on the left-hand side, the leading hand showed easily corrupted, a lot of phase dispersal. And of course, if we just take a naive sequence and apply it, it's probably not showing so well on the screen here, but you don't see anything in the myocardium. And I think that bottom right picture is defining what my Ph.D. was for 4 years. Basically nothing. And I think that nothing came out of it, and I just kept doing it over and over again, right? It's insanity. So you can see it's very challenging because you can't just stop the heart. It doesn't make any sense. People take the hearts out all the time, and they did it, and so that's what they were doing for 20 odd years. And so let's talk a little bit about the physics. I promised not, Mike, I wouldn't show an equation, but I did anyways. And if we take a quick Taylor expansion, looking at sort of the gradient moments, I guess that most people take an MR course, you see sort of that first term right here. The teacher says, this is how we define phi, and this is how we get our phase. But they kind of lied to you because that's assuming the tissue doesn't move. And if you Taylor expand out, you can start seeing there's dependencies on velocity and acceleration. And that's bad. That means that if it's moving, you have additional phase you didn't count for. And frankly, you won't know where you are in K-space, and that's why you have basically no signal. You're completely dephased. And unfortunately, we are using gradients to sort of encode our diffusion rating. Well, let's say, okay, let's be smart about it. The heart has to stop at a certain time. So if you look at these, sonomicrometry sort of, what they are basically is beads on the heart, and they sort of track the motion of it. You start to see in these red boxes here where the heart kind of pauses. And so maybe we could just gate it. Unfortunately, that first image I showed you was gated. We tried that. It didn't really work. But maybe there's a way to be sort of clever about it. And so sort of the first set of imaging that they've done is sort of the stimulated echo. It had some very nice features to it. It's a genius idea. It came out of here, of course, with MGH, with Bob Edelman when he was here, and with Van Wedeen, who all started it off. You didn't know he did cardiac diffusion too, right? And what the clever idea is here is that we do the first half of the diffusion encoding at a particular trigger delay, and then we tip it up onto the 90, and so that way we're not sensitive to motion during the cardiac cycle. And then we tip it down again, and then we encode for the rest of it. Very genius, right? Because those two, if the heart rate is exactly the same, and we sort of, leveraging periodicity, they should be in phase together. And so, there's some disadvantages and advantages. Like the key one is that it has to be, in this case, no arrhythmia, which unfortunately with most heart disease there is, but that's okay. We just need to get first some of these interesting. The other thing is that you only need small gradients. So back in the 90s, that's a good thing because we only had max 10 millitests per meter, which is, compared to the 300 at the connectome and beyond for connectome 2, it's pretty impressive. You also don't need to do the 180 refocusing pulse. So there's lots of pros and cons. The big deal that I want to put forward is that the periodicity has to be there. So 1, they're going to have to hold their breath, and 2, the beat has to be uniform. And so here in the 1994 image here, that's the first image of a cardiac diffusion-weighted image in the heart. And they were looking at sort of this thrombus over here. You can see that in sort of that bright region over there. And they just wanted to demonstrate that that had some restricted diffusion left over. And then as you go forward here with Tim Rees, Shuki Makawi, David Sosnovic, all of those folks have pushed that field forward with, of course, Van Wedeen. And we've now gotten to the point where it's gotten better. They've changed things to be a zoomed readout. And you can see that essentially that sequence has just been the workhorse of our field for in vivo work. But again, we have some problems with that 2R to R. So then I came along and I said, okay, we need to move this to patients. And at the time they were, but there was only like maybe a couple centers doing it. So how do we make it so it's for the masses? How do I make a Honda Civic out of a Porsche really beautiful sequence, okay? So the way I thought about it is that, well, why don't we, instead of trying to do this periodicity and use gating, why don't we go ahead and start to null? If we go ahead and null and design our gradients so that this M1 and M2 is basically 0, then we should be in a good place because the heart doesn't move faster than the change of acceleration. At least there's a couple places that it pauses, so it should work pretty well. And so I started looking at some papers. There were some groups that were looking at sort of just doing velocity compensation. This is very familiar to you in this top row here, what they do for flow compensation. And then I started to make all these different pulses, which are on the bottom, to sort of get the second order motion compensation. And it seemed to kind of work. It actually worked very well. There is some sort of catches and caveats. One, we needed the high gradient system. And funny enough, Prisma came to pass. We also pushed even the 40 millitests per meter system to work well. And the connectome and some of the pigs that we showed, I don't have that data here, but those heart rates are much higher, and we can do that no problem. The key disadvantages, I would say, besides the hardware, is that maybe there's a 180 pulse that you have to consider. But the nice thing is that you do a single heartbeat, single encoding. That opens the door wide open to do a lot of the free breathing and sort of connect in with the cardiac world to be able to do sort of the images. And so the recap that I just want to show you, that there's a lot of work that has been going on in this field. And we've gotten some more of the complexity here. But that sort of results, these results kind of show us right here that things are working. But I was a little cautious, and so I wanted to sort of validate. So I took a step back and I said, okay, technically, diffusion is not looking at the fibers directly. Technically, we're looking at water and how it diffuses in the syncytium. And we assume that the water diffuses along the main eigenvector, and that is going to be in the same direction as fibers. And so we did clarity. We did clarity in the heart, and we did it in some mice heart. We cleared it. And then we said, OK, now we're imaging the fibers. And now in that same heart, we're going to go ahead and do some ex vivo DTI just to demonstrate and make sure. And the proof of concept is that you would do an in vivo image, then you would do an ex vivo scan, or you just do the in vivo image, and then you take the heart out in animal models, of course, and then check again. We did that, and we showed that it works very, very well. You can see even in this sort of GIF file that it has this circular swirling pattern, because in fact it does have that double helix that we saw. We also did it in the case of sort of large animals for our pigs that we did. We did some clearing here. This was even more challenging. This is the work that we did over here. That's roughly 1,000 times larger in volume. So that took days to clear as opposed to a couple hours that most people do with the active clearing. And we could, of course, we could not get the entire pig heart because it's huge, but we could take a section of it and go from transmural, which is that red line there. And we can see indeed it goes from a right-handed as it goes into the left-handed, and we can look at the comparisons between the in vivo DTI and sort of clarity. And so let's talk a little bit about, we have a sequence, we know it kind of works, we know that we have signal. What can we do? Now it's time to run. Now we caught up with the brain group. We now can press a button and it kind of gives us images. What can we do with it? So the first thing we did is said, okay, well, we need to be faster because we need to get a lot of directions and we need more averaging given that it's cardiac application. And so we did sort of this multi-slice push-button sequence. And so you can imagine we're just capturing a bunch of slices and then retrospectively binning them with low-rank tensor. There's a more recent paper in Nature BME that looks at multitasking. And all that is that you're just going to reconstruct in the low-rank tensor domain respiratory motion and diffusion contrast. And so then you can then have this retrospective motion correction. And you get wonderful images. These are images that are B50 and B500 in vivo in a subject. And then we scanned it like 2 months ago or something like that. We can even do it even yesterday and whatnot. And you can see that we're going from the base of the heart all the way to the apex. And then you can reconstruct getting MD, FA. HA is this sort of that helix angle. Remember, we showed that concentric rings. You can see that here in the in vivo images. And then again, this is sort of that tractography we talked about. And these are different reconstructions in different views in this bottom row. So this is sort of a near push button, 12-minute scan. It's free breathing. It has 100% gating efficiency. These are all the work that my other lab did on coronary imaging. We just sort of finally, once we had a great image, we sort of hooked up with that lab and got that technology sort of put in. And then a little bit of showcasing of the work done here. I know some of the groups are very familiar with sort of G-slider in the brain. It's gorgeous. It makes a lot of sense. And from the cardiac point of view, we could really benefit from it. Because if you look at this, if I did a reconstruction on the left hand, sort of the long axis view, you see it's quite blurry. And it's because we take these very thick voxels due to the fact that for the myocardium, the T2 is so short. And then, of course, the heart is so deep inside a person's body that we have sort of low coil sensitivity. But then you can do these same motion reconstructions, but just do the RF encoding like you G-slider, and you can reconstruct it. This is a very long scan, but this gives us potential, because now instead of like 8 slices, and you think that's really difficult to do with tractography, it is, but now we have like 50, right? And so now we can do some beautiful things. This is work that, with this G-slider work is sort of pushed and the leadership was Shuki Makawi. He said, I really want to do this, Chris. Let's do this. And so we put all our heads together with Cowan's group and did this. And this is sort of the results that we get coming out. This is a wonderful way of representing our data. For the longest time, we have these little donuts that everyone's been looking at. But now what we can do with that arrow showing is that we sort of slice down from base to apex and open up the heart. So we have this sort of unfolded representation. And I think that really opens up the door on how we visualize our disease, and more importantly, be able to quickly identify it. And so with that, we only had 10, 15 minutes, so I'll be quick about it. In vivo cardiac DTI is sort of not faint for the heart. It's really challenging just due to the fact that you have motion, but I think we're at sort of that cusp of it. We've done some clarity-based tissue clearing to just demonstrate, from first principle that we know that the DTI is showing and reflecting myocardial microstructure. And then sort of our recent advances in our tools have really shown that we can really push it. We're at a very exciting era. We're at a time where pretty much anyone can do it. I think after my paper was published, there was, hundreds of papers that came out afterwards where people are just doing it, and we're just sending our sequence out and then having groups sort of recapitulate the findings that we had, and then furthermore bring the field forward. And so I think this is very exciting. I just want to say thank you to sort of my group there. Mike is one of the members of our group. And that's it. So